Well, good afternoon, ladies and gentlemen, and thank you for that introduction. It's an honour to address this Sitra Talusanamat seminar. I'm sorry that you have to listen to me in English. Despite several visits to Finland, my Finnish doesn't seem to be making very much progress. This talk is based, of course, on a review that the OECD conducted of the Finnish health system. The review was carried out mainly last year in 2005, and the review was carried out at the invitation of your Ministry of Social Affairs and Health. This is quite normal that member countries ask the OECD to look into some aspect of their economy, or in this case health system, that they want some external advice on. And as must be obvious, this talk is very much based on the experiences of some outsiders trying to look in on Finland to try to understand both the achievements and the problems faced by your health systems, to compare them in an international context, and to come up with some suggestions and recommendations for the future. So, the structure of the talk is like this. First of all, I'm going to look at how the Finnish health system has performed from an international perspective against three sets of objectives, really. The sustainability of the system, how affordable is it and will it remain affordable? Value for money, how efficient is the system, and how equitable is the system, how fair is it in giving health services to all Finns, all members of the population. And there were some topics of special concern that the Ministry asked us to look at: growth of drug spending, the effects of decentralisation, securing human resources and tackling excessive waiting times. So I'll mention those from time to time. We take a quick look at what has been done to reform the system already, and we then turn to the question of what are the options for the future, and we offer some OECD assessments and recommendations. Now, this is one version, one diagram of the structure of the Finnish health system, and I'm putting that up there to draw attention to three issues which we thought were very distinctive about the structure of the Finnish health system, and perhaps problematic as well. And the first one is that there are two parallel sets of funds and services. Over on the left-hand side is the social health insurance system, the Keller part of the system, and private services, and drugs are there as well. And over on the right-hand side of the diagram is the municipal system. And the three things that are distinctive in the structure, I think, are that there is this parallel funding, which is rather unusual, and the reliance predominantly on the Nordic model, on the right-hand side, the municipal system being public ownership and public finance of services. And finally, the third distinctive feature about the Finnish health system is the extreme decentralisation, with, I think it's 432 municipalities, at least there were last year, running the system, the municipal part of the system. Now, this is a well-known part of Finnish history, and I won't spend very long on it. This is the growth of GDP on average in the OECD countries as a whole, and that was the track of GDP per capita for Finland. And of course you had your major recession in the early 1990s, which was a big shock to the system. And that's the growth of health expenditure in OECD countries on average health expenditure per capita, and this is the track for Finnish health expenditure per capita, and a rather remarkable phenomenon. This doesn't very often happen, that health expenditure per capita actually fell, and it demonstrates, I think, a remarkable degree of control that central and municipal governments have over the rate of growth of the system, that the reaction of governments to the economic crisis was to cut health expenditure. And that, I think, the blue dotted line is the average GDP share for OECD countries, but the Finnish average, the Finnish GDP share, health expenditure share of GDP, rises dramatically in the early 1990s as a result of a slightly delayed reaction to the shrinking economy, and then it falls sharply as the governments, both central and local, start to restrain the health expenditure, reduce health expenditure, so you have the sharp fall and then the resumption of growth again about the year 2000. And that was the peak. And that all followed the transfer of financial responsibilities to the municipality. And the result of this is that, I'm just trying to put the mouse, there's Finland, with a low GDP share, 7.3%, lower than most OECD countries, and this rapid fall in the during the 1990s. Now, there's part of the system that doesn't look quite so well controlled, and that is drug spending, which is an interesting part of the Finnish health expenditures, because it falls between the Kela and the municipal authorities, and we think that's a very significant fact, that drug spending is decided mainly by people in the health centres and in the occupational health services, and the actual spending falls under the Kela, so there's a separation between the decision to prescribe drugs and the public subsidies, the spending of public subsidies to support drug consumption, a separation between deciding about spending and actually meeting the bill, which we think is a big problem. Now, the rise in drug spending as a share of GDP, which is what this slide shows, has not been particularly different from other OECD countries or from the other Nordic countries. So it doesn't look very much of a problem when you take it as a share of GDP. Okay, it's rising, but then this is normal. It's rising in other Nordic countries and in other OECD countries. But when you take the health expenditure share, the drugs share of health expenditure, it looks more of a problem, because in the late 80s it was low in Finland, similarly to other Nordic countries. I'm trying to move the mouse pointer. There it is. Finland starts off with a low drugs share of health expenditure, and then it rises very steeply in the 1990s and converges with the OECD average. So there is some sign there that drug spending is less well controlled than in the other Nordic countries, and in a sense less well controlled in the other OECD countries if you take the rate of growth of change, although the level is still not abnormal. Now, I'm now coming to these are really issues, the issues I've just been looking at with these transparencies are issues about the sustainability of the system. The good story about total health expenditure and its control in the 1990s at a difficult time, and the more problematical picture for drug spending, the drugs bill. And I'm now moving on to the issue of value for money, and these are the inputs, the real inputs to the Finnish health system, and the resources used up. And this cobweb diagram shows levels of utilisation of inputs in the Finnish health system compared with the OECD average. And the dotted line is the OECD average, and the sort of inputs we're comparing are At the top, general practitioners per 1,000, if you can't read that rather small writing. Moving over in a clockwise direction to the right, practicing specialists per 1,000, nurses, acute beds, long-term care beds, chemists, and coming back nearly to the top, pharmacists per 1,000 population. And you see that it's a rather mixed picture for Finland. Finland has a lot of pharmacists, a lot of dentists, and a lot of long-term care beds, not so many acute care beds, and relatively fewer doctors, both specialists and general practitioners per head. So it's a somewhat mixed position. So the low spending sometimes turns out to be associated with rather high inputs and sometimes with rather low inputs. Moving on, these are the activities of the system. They are, in a sense, the intermediate outputs from the system. And again, we have a mixed picture. Up at the top, we've got doctor consultations per capita, and they're looking a bit low. Finns seem to visit doctors less often than in the average OECD country. The dentist's visits are typical. The hospital discharges are surprisingly high for Finland, despite the acute beds being rather low. The day surgery cases, well, I'm not sure the data are as good here as in some areas, so they look a little bit low for Finland, but that might be the data recording. I should just say something about these data. These data are all taken from the OECD Health Database. They're international comparisons. International comparisons are difficult. It's difficult to compare nurses, day cases, consultations with doctors across country. These are the best data we know of. We've taken some care to try to make them as comparable as possible, but they are not perfect. So you're entitled to look at them with a small amount of scepticism as to whether they're always telling a completely accurate picture. I can't pretend these are necessarily the final word on comparisons between Finland and the rest of the world. And of course, this is a fairly easy test for Finland. We're comparing Finland with the OECD average. We're not picking out the 5 best OECD countries on any of these indicators and asking Finns to compare themselves with the 5 best. We're just comparing Finland with the average. Now, this, I think, is a very interesting story about Finland, and I think that it affects the way Finns should think about waiting times for surgery, which later on I will suggest is apparently a problem, as you well know. These are the rates of surgery for some of the elective surgical conditions that where typically you find the long queues forming. Coronary artery bypass grafting, prostatectomy, hysterectomy, hip replacement and knee replacement. Now, there are 2 OECD averages here, 2 lots of dotted lines. The inner dotted line are based on a number of countries which we know have waiting time problems. They report long waiting lists like Finland. They include my own country, the United Kingdom. They include Australia, Canada, the Netherlands and some countries like that. That's the inner dotted line in the cobweb diagram. The outer dotted line are the surgery rates for these conditions, which are reported by a number of countries which do not report having waiting times problems. They include Germany, Belgium, Austria, France, and a number of countries like that. They're mostly in the West and in the centre of Europe. And these countries simply don't have any problem with queues. There aren't really good international data on the waiting times, but all these scraps of information and the reports we have from these countries suggest they don't have problems. Now, look where Finland is. Finland's rates of surgery are mostly up at the same level as the countries which do not report having problems with waiting times. Finland is not a neighbour of the countries which do report having waiting times problems. They have lower rates of surgery. So what's going on? Well, we think, to simplify a complicated story, we think that it may be that the problem in Finland is not too little surgery. it's inadequate or some problem with controlling the demand for surgery. There are too many people being added to queues unnecessarily compared with other countries. When I use the word unnecessarily, I mean compared with the standards of queuing set in other countries. Finland is a country, when you look at its surgery rates, which should not have queues. So the queues are not a problem of needing to increase surgery rates. They're perhaps a problem of handling the queues and of managing the queues. This is our suggestion. Now, an extremely important question is productivity in Finland, and we've already heard today that measured efficiency has been falling in the Finnish health system. We're a little bit sceptical about those figures of measured efficiency falling in the Finnish health system. They are, of course, very carefully compiled figures. We're not questioning the accuracy of the data, but we do question their meaning. We think that they don't include any allowance for quality, improvements in quality, and that the productivity situation in Finland might well look a lot better if there was some more allowance for quality in the figures. And Britain has just gone through a very similar experience of finding falling productivity as measured by the official figures produced by the Central Statistical Office, the Office for National Statistics, as it is now called in London. But when they made some quality adjustments, the picture was transformed. These quality adjustments are quite controversial. You can't say we have a recipe for how Finland should do them. It's going to be a long, hard task to adjust for quality, but it does change the picture, and it looks much better when you make some allowances for quality on certain assumptions which can always be challenged, so it's not uncontroversial. Now, these are the cruder sort of productivity measures that don't adjust for quality. I'm going to come to quality in just a moment, but let's just look at the crude measures of the kind that do tell that there's been a deteriorating situation in Finland. And they suggest that the picture is quite mixed. Up at the top, defined daily doses of drugs per pharmacist. Seems that productivity in that respect is low in Finland, perhaps because there are rather a lot of pharmacists. The consultations per physician look quite low. That is consistent with what we know about how long the length of consultations, for example, with doctors in health centres it's long by European standards, so they don't see so many patients each day. The consultations per dentist seem low. However, the hospital discharges per specialist seem extremely high in Finland compared with the average, and so on. The last figure over on the, as you're facing it, left-hand side of the diagram, the inverse of the administrative share of health spending. It's been inverted, so being farther out in the diagram is a good thing. What the story is that administrative costs as measured in Finland are extremely low. This is a very thrifty system that doesn't spend a lot of money on bureaucracy. It might seem like that, but the international comparisons don't suggest that it is. Now, I'm coming to the first part one of the quality comparisons, and this is the public health side of the story, and comparing a number of measures of public health performance in Finland. This diagram, I'm sorry about this, it got changed in the report we published, but this is still, in a sense, the wrong way round. Here, and I apologise for this, you should look for a lower value to be a better performance. This is avoidance of public health risks. And the risks avoided are low birth weight percentage up at the top, AIDS incidence extremely low in Finland compared with the average OECD country, moving in a clockwise direction. The inverse of the DTP immunisation rate, kids immunisation rate, not so good for jabs for the elderly, for flu. That doesn't seem quite so good. Tobacco consumption's a bit on the low side, and alcohol consumption's a bit on the low side compared with other countries. So there seems to be a lot of good public health story there. And these are quality indicators for, how should I say, the acute part of the system. And these are some early experimental measures that we've collecting at the OECD with the help, of course, of people in many countries, including staff in Starkes who've sent us the Finnish data. And these are measures such as cancer survival, male and female, at the top male, female going round clockwise, femur fractures operated on within 48 hours. This is elderly people falling over and breaking a hip. And as I understand it, I'm not a medical person, as I understand it, it's very, very desirable to get those hips repaired and to reambulate, to get the elderly people out of bed and get them home as soon as possible, resuming their lives, because lying about in hospital is very bad for you. So operating it within 48 hours is a good thing, and Finland does very well in that. Mammography screening rates are very high, cervical screening rates are okay, and functioning kidney transplants as a percentage of all renal failure patients is a good one. So that's only a tiny handful of measures, and maybe if we'd had a different handful of measures, the picture would have been different. These are early data. We haven't got very far with this project trying to compare quality, but so far as it comes out, the story for Finland is good, and this is completely consistent with a strong impression we obtained as foreigners visiting Finland and talking to a lot of your doctors and nurses. We were hugely impressed by the professionalism and the commitment that your professionals, your health system professionals, seem to have to the task at hand. It really seems to me that there's a lot of excellent medical and nursing work going on in Finland, and perhaps these statistics are evidence that that is so. Now, this in a way goes back to the public health story as much as anything. Just some measures of health status in Finland, which, as you know, comes out quite well compared with expectation of life and so on, compared with other OECD countries. And these are some life expectancy at 65 figures, and Finland, the rate of improvement of life expectancy is growing faster since the 1970s than other countries. And this is the remarkable picture for coronary diseases of the circulatory system, which I think is an example to many countries abroad, the way in which the lifestyles in Finland have improved. It's probably improvement in lifestyles, and the North Karelia project and the gradual learning from that took place throughout Finland, and the very high coronary death rates and the rapid fall in those coronary death rates and the convergence, so that Finland is beginning to look like an average OECD country. Of course, you could still say, well, there's still further to go, but progress is not bad at all. However, now we come to two less attractive parts of the health system. So far, I think the story has been one of great achievement, not entirely unmixed perhaps, but many, many good signs. But there are aspects of your Nordic model of healthcare delivery, or perhaps it's the combination of the Nordic model and the parallel funding, the institutions you have here and the decentralisation, where the performances don't seem so good. And first of all, there's some figures here we took out of a comparative study of general practice performance across European countries, and it seems like the waiting times to see general practitioners in health centres are pretty long in Finland. This is the percentage of general practitioners with average delays of 2 or more days, and it's 80%. 80% of Finns, when these data were collected, waited more than 2 days, or 2 days or more, compared with 5-6% in the Netherlands, Iceland, 12% in France, and so on. So Finland's wait a long time to see a physician in a health centre. And this goes along with a certain type of working in health centres. I mean, on the one hand, we were very, very impressed when we visited health centres here in Helsinki, and we went up to Oulu in the north last February, and we went to Haukipudas, and we spent a few hours in the health centre there talking to staff, and we made a tour of the premises, and we met some patients, and we were very impressed. We thought it was a wonderful institution with a whole range of services and inpatients all under one roof. But there does seem from the statistics to be a certain pace of working and a certain style of working which is probably contains medical and professional excellence, but doesn't seem hugely responsive to patients. And these are arguably the two criteria that we must apply to health systems. The two criteria are what good does the health system do for the health of the population? What's the health outcome produced by the health system? But the second question is, how responsive is it to patients? How does it feel being a patient? Are they seen quickly? Are they treated kindly? Are they given good explanations for everything? Now, perhaps the Nordic model is not so strong in the second respect as it is in the first respect, at least in the Finnish version. And as I mentioned earlier, there is evidence that Finland appears to have problems also with waiting for surgery. And indeed, when we at the OECD carried out a project to measure waiting times across countries and to try to explain why they varied so much across countries, because they do vary hugely, waiting times for surgery, and to identify ways in which waiting times might be reduced, we found that the data that were reported to us for waiting times suggested that Finland had really the longest waiting times amongst a rather small group of countries, very close to the United Kingdom, which is well known for its waiting lists, but a lot longer than countries like Denmark. And although we couldn't collect the figures for Germany or Belgium or Austria or France or Luxembourg, they would be much, much shorter than these. They're just a few days or a few weeks. We know that from small surveys of waiting times for particular hospitals and so on in countries, but we don't have official statistics that we can compare. So there appears to be a problem there. But is that really a problem? Well, I've discussed that already. You have to take that alongside the evidence on the surgery rates, which seem to be very high, unless somehow Finns need much more surgery than anybody else in Europe. Is that possible? So we think that's something to do with the management of the queues here, and we think it's something to do perhaps with the incentives in the system. Perhaps the municipal system and the hospitals. The hospitals find that they must have queues to argue for the budget. You need a long queue. Money follows the queue. Never mind patients. Money follows the queue. And the doctors have every incentive to have long queues because they have private practices. And therefore, it's a good thing to have a queue, because otherwise the private practice would not have so much demand. So it's perhaps something to do with the way things are being managed here that explains this long waiting time. Now, this is the third area. My first few slides were about the sustainability issue, the affordability, the control of overall spending. Is the health system affordable? And it turned out that, yes, the health expenditure share of GDP is really, really low in Finland compared with similar OECD countries. And then we went on to the value for money, and we've seen various bits of evidence about costs and quality and inputs and outputs and productivity as best we can. And this is the third part of the story, the equity part of the story. And you've seen a slide like this already this morning, I know, so I expect you're a little bit familiar with it. It's a little bit hard to explain these things, but you should look at the line roughly in the middle, which is where I'm just trying to run the mouse arrow along, not very successfully, this point here. That's the zero line. Now, any of the dots, the black dots that are below that line, it means that that's a country, and the countries are Ireland, Belgium, Spain, United Kingdom, Netherlands, Greece, Denmark, Italy, Switzerland, Hungary, etc., etc., and Finland right at the right-hand end. Finland's right at the right-hand end. If your dot is below the zero line in the middle, horizontal zero line in the middle, you have pro-poor use of general practitioner services. That means the poor people with low income, allowing for their health status, get more access to GPs than the better off. If your black dot is above the zero line, it's the opposite. It's pro-rich. It means that the well-off are getting more access to general practitioners after allowing for their health status, their state of health, than the low-income people. It's inequitable in that sense. And the story is that Finland is the most pro-rich among these countries compared. And the reason for that, I am told, is that you have occupational health services. And the people who have a job tend to be in the upper part of the income distribution. And they get very easy access to plentiful occupational health services. They, as I understand it, you may have more detailed experience which would suggest that what my understanding is not quite right, but as I understand it, you would be able to see a doctor usually the same day if you go to work and you want to consult an occupational health doctor. Whereas, as we've seen, the folk who go to the health centre, and I know some of those people are occupational health patients, but most of them are not, they have to wait quite a long time sometimes. So that's what probably, that together with capacity restrictions in the health centre, produces an inequitable picture. And there's a slightly similar but slightly dissimilar story for specialists. And the story here is that nearly every country in the OECD has inequitable access to specialists. And this is something a bit puzzling that we don't really understand and requires more analysis and more data gathering. But it may be something that was said this morning that gives the clue. The clue that what was said this morning, I think, or what was said provocatively this morning, is that the rich will always get better access to services. And that does seem to be true when it comes to consultations with specialists from this set of data. Most countries lie above the zero line. Most of them, the middle classes, it seems, are getting better access to specialists than the lower income people. But Finland is again somewhat towards the second to the end on the right. In other words, Finland is more pronounced in this inequity than most other OECD countries. And my understanding is that that might well have something to do with the fact that you have private services which are partly supported by the Kela, and people with, but not supported very much. So people who visit the private sector in Finland are going to be higher income people, and they're going to get quicker and easier access to specialists than people who go to a health centre and then get referred to a district hospital or wherever. On the topics of special concern, I think probably, yes, I can say a little bit about this. Well, we wondered whether there was some evidence of rather high margins for pharmacists, but a lot of that seems to be to do with tax and VAT rates in Finland and so on, rather than perhaps excessive profits by the pharmacists. Decentralisation, we felt that there probably was some adverse effect of decentralisation on efficiency. I don't think that's a particularly controversial remark. Very small municipalities must find it difficult to play their part in managing health centres and hospital services, particularly hospital services. Human resources, there are some shortages now and a considerable threat in the future, as we've heard this morning. And waiting for surgery, well, I've been over that already. We think it's more lack of demand management than a lack of supply. There have, of course, been what we considered to be some well-judged reforms in the health system, particularly as a result of the national project on safeguarding the future. Our understanding is that action has been taken to boost human resources, which was necessary. that waiting times for surgery have been coming down, which is the right direction. But I did hear in translation criticisms this morning about not sufficient implementation of these reforms. So I guess that Finnish people will just have to see what happens on that. We thought there had been some important reforms to the regulation of prescribing, with generic substitution, Keller feedback to doctors about their prescribing levels and costs, and the ROTO scheme and the Pharmacotherapeutic Development Committee, I'm not quite sure I remember the right title, the PDC, which is going to be guiding and advising doctors on their prescribing. These seem very sensible reforms to us. There have been some important local reforms, and so we thought this was all very sensible. However, we, not surprisingly, and we've heard a lot about this today already, detected some quite important challenges to the Finnish health system, threats to public health such as growing levels of overweight and obesity, smoking and alcohol consumption among teenagers. It would be a great pity if Finns gave up their reputation of being some of the most active adopters of good lifestyles, because you've earned that reputation as a result of the developments in the 70s and the 80s and the 90s, but will it continue? There are certainly threats to fiscal sustainability. I think, again, we've heard about this morning. Cost increasing technological change, I think, is at the top of every expert's list. We're all expecting a torrent of new inventions, which will not be cheap. They'll not be low-priced. They'll be very high-priced. They involve all sorts of revolutions, innovations associated with developments in genetic medicine, which will enable treatment to be personalised, so that people will be able to give individual treatments. But this is going to surely cost a lot of money. And will public systems be able to afford to pay for that? Rising expectations. People expect rising service standards. As service standards rise in other parts of the economy, people expect the health system to treat them better and quicker and more effectively. And of course, threats to the health workforce. Again, we've heard about this today. The difficult situation that Finland faces with a rapidly ageing population, that many people will retire and ageing will add to the demand for healthcare, and at the same time the workforce is going to be retiring, so there's a problem of sufficient recruitment, and that's particularly acute in Finland. But people looking at, say, events in France today, or the general strike that is planned for next week in France because of reforms to the labour market that the French government is hoping to bring in. They point to Nordic countries, and Finland is one of them, and they say Nordic countries have already done more to reform their systems and to prepare themselves for the ageing problems ahead. And they contrast the action that is being taken in northern countries with the inaction and caution of governments in places like France. These are the demographic trends. These perhaps exaggerate the difficulty because they're the rates of change rather than the levels, and I do apologise that I haven't brought the rates of change figures with me, but Finland is the solid line that has a dramatic peak in about 2010 or 2015, when the rate of increase of those over 65 exceeds that in all other European and I think OECD countries. No, it's Norway, Sweden and EU countries, so this is just a European picture. So there certainly is a mountain to climb there. So this is bringing these points to a sort of conclusion. We've done some diagnosis. This is the last stage of the diagnosis. In a moment I'll be talking about prescriptions. The diagnostic assessment is summarised in the following way. Sustainability Well, the GDP share is in a strong position at the moment. The base you start from is in a good position. But when we visited Finland a year ago, more than one municipality told us that their feeling was that health expenditure was getting out of control. They spoke about the hospitals coming to them with demands for expenditure increases, which they could not control and they just had to accept. So there may be a risk there that things are slipping out of control. And we've discussed, I've presented you some of the evidence on pharmaceutical expenditure, which was an issue that the Ministry particularly wanted us to look at. Value for money, well, input levels are at or above average, except for physicians in acute beds. There are mixed productivity and utilisation rates, which might be as a result of the Nordic model. Perhaps this isn't the most efficient model that Finland can find. Does it need reforming? Is the productivity evidence a sign that you need to look for a more efficient model? Good preventive and technical outcomes, but long waiting times for some services. And is that a result of the Nordic model or parallel funding? And finally, equity. I didn't mention equity of finance, but it seems very fair in Finland. This is one of the questions you can ask about a health system. How is the burden of payment distributed across the population? And apparently the answer in Finland is that it's distributed roughly proportionally. People pay roughly in proportion to their income, which is a lot different from what it would be if you had a private system, when the payment would be much more heavily bearing down on the poorer parts of the community. So there's a lot of redistribution going on in the financing. But when we come to the services, we've seen this evidence that, and it's rather surprised, people in other countries say Finland has unequal access to services. They're very surprised. And it's not until you understand the way the systems are designed and the importance of occupational health care, which we're not criticising. We think it's great to have occupational health care, but it does have this side effect that some people get faster access to services, it seems, general practitioner services than others. So, I'm turning now to the future, which is rather late in the talk, given the title of this talk was about the future. And these are our suggestions as outsiders for some things that Finland might consider doing if indeed these challenges are real ones lying ahead. And as far as sustainability, affordability is concerned, we think you should give consideration to improving control over hospital spending by greater centralisation of financial management. This is one of the areas where we think small municipalities may be a problem. Transferring responsibility for prescribed drugs spending to municipalities from the Keller. Now, this is a really big structural change. It may not look very big. The suggestion is you should think about having drugs budgets in health centres so that the public part of the spending on drugs is located, the responsibility for that spending is located where the decisions on the prescribing are taken. So there should be a health centre drugs budget, and every general practitioner in the health centre should be aware of the state of that budget every month. And they should be able to redeploy. If they make savings, they should be able to redeploy the savings within the health centre. So there's a powerful incentive to look at prescribing and say, do we need so much prescribing in this health centre? And the same should apply, something similar should apply to occupational health services. When it comes to private consultations, we think the patient should pay all of it. No more subsidies for drugs, private drugs. Let the private sector stand on its own feet when it comes to prescribing. There might still be subsidies for consultations with specialists, but the drugs should be private. So this would introduce some coincidence between the spending, the public spending on drugs, and the prescribing. And we make some suggestions for increasing efficiency, which come on the next slide. So, in primary care, we think Finland maybe could do with some more choice of physician and a bit more flexibility as far as the patient is concerned. At the moment, as we understand it, it's mainly geographical zoning, and you go to you have a doctor as assigned depending on where you live. This is not very much choice. And we think that that choice mechanism should be linked to performance payment incentives, certainly for doctors in health centres and perhaps for all the workers in health centres, so that there's some sort of financial reward that is linked to the performance, particularly the performance, say, in terms of waiting times in the health centre, so that good, quick, fast, responsive services are rewarded. This is probably not easy to devise a system, but when you look at the countries in Europe that have fee-for-service payment, and we're not advocating complete fee-for-service payment, if we advocate anything, it's a mixed system where you have some capitation or salary payment and some fee-for-service patient. The countries that have fee-for-service patient, the doctors work much longer hours, 60 hours compared with 40 hours in Finland per week. They have shorter consultation times. They don't have waiting times. It's a completely different picture in terms of responsiveness. So that model exists. It's there just across the Baltic Sea, in Germany, for example. We're not suggesting Finland should imitate Germany, but there are lessons we think can be learned in a small way for getting a little bit more speedy responsiveness out of health centres. I must bring this to a close fairly soon. Specialist care, we have a number of suggestions. Reducing the number of hospital districts. Of course, your project on restructuring municipalities and services will be deciding on that very soon, as I understand it. Thinking about introducing purchaser-provider separation, more independence for hospitals, and requiring market testing, at least for support services. Perhaps with some competition where that's appropriate. Establishing a uniform system for pricing hospital services. As we understand it, you cannot compare prices across Finland at the moment for hospital services. But you do have Nordic DRGs, so we think it wouldn't be a huge technical task to have some uniform system that would enable comparisons of price per patient, cost per patient by DRG groups across Finland, and on that basis to benchmark efficiency. Devising incentives for achieving waiting time targets, perhaps incentivising better management of those surgery queues, and making NHI subsidies, national insurance subsidies for private consultations, conditional on a GP referral, as in many, many other countries. Value for money, human resources, various action we suggest to boost the supply of resources in a tightening labour market. And finally, equity. Well, the savings on the drugs budgets, the hypothetical savings on these drugs budget we're suggesting, could be used for this incentivisation scheme in the health centres, and perhaps for increasing the numbers of GPs. And we think that there's scope to review the formulas for funding the municipalities from an equity point of view. So to conclude, and I want to leave 5 minutes for questions if there is 5 minutes, 3 minutes. Very broadly speaking, we think the Finnish health system has performed relatively well. We think that to external view, this is a good system. It has not broken down. It is not looking in imminent state of collapse. It has much to commend itself for. However, it does face challenges ahead. I think everybody agrees on that. And we do think it's hard work, I know. We do think the reform process has got to go on. So I'm going to stop there, and if there are any questions, and there is time, I'd be welcome hearing them.
Okay, thank you, Mr. Jeremy Hurst. Very We just might have a few minutes, 1 or 2 or 3 minutes time, if there are some questions you want to put in the audience for Mr. Hurst. You know, Finns are silent folk. But, As I listened to your presentation, it was very, very interesting. It was very interesting to hear outside view of a Finnish healthcare system, and there are some things which was a surprise to me too. For example, the queues. Do you really think that Finnish system is such that we put people or patients to the queues without no reason?
It is a possibility. I really think it needs more investigation. You know, the variation in surgery rates across the OECD, both across countries on average and within countries by small areas, is incredible. There's this incredible variation. You can find towns in America where the hysterectomy rate is 10 times what it is in another town. Now, this cannot be explained on demographic grounds, on epidemiological grounds, on socio-economic grounds. It is something about surgery that a lot of the demand for surgery is in the eye of the surgeon.
Okay, thank you very much. And thank you very much for the presentation. I think it gave us a lot to think about. It was a great pleasure to have you here, Mr. Hurst.
Thank you.